Hello, Dr. D here. This recording is the first in a three-part series pertaining to chronic obstructive pulmonary disease. Part 2 will focus on the various treatment options to manage COPD, and Part 3 will be a real-life case study. The purpose of my videos is for healthcare professionals to refresh their knowledge or to assist students studying to become a healthcare professional in their studies. Also remember, you can use this platform to do your CPDs and use it as evidence if it applies to you. But for now, let us start with an overview of the disease. COPD is a heterogeneous lung condition characterized by chronic respiratory symptoms due to abnormalities of the airways and/or alveoli that cause persistent, often progressive airflow obstruction. This lung disease is chronic and progressive and cannot be cured. COPD results from gene-environment interactions occurring over the lifetime of the individual that can damage the lungs and/or their normal development or aging processes. This is referred to as genomics. Pertaining to genetics, mutations in the SERPINA1 gene leads to alpha-1 antitrypsin deficiency, which is a plasma protein synthesized in hepatocytes. Its primary role is to protect cells from destruction by elastase. Alpha-1 antitrypsin deficiency is inherited in an autosomal recessive pattern. Remember, we have 44 chromosomes or 22 pairs and 2 sex hormones, XX for females and XY for males. An autosomal recessive disorder means 2 copies of an abnormal gene, one allele from each parent, must be present for the disease to develop. Cigarette smoking is the most common risk factor, and smokers are more likely to die from COPD when compared to non-smokers. The age of starting, total pack years, and current smoking status are predictive of COPD mortality, therefore the T for over the lifetime. Pipe and cigar smokers do have a lower risk, but it remains higher than in non-smokers. Vaping and the use of e-cigarettes are independent risk factors in addition to combustible tobacco smoking. People exposed to passive smoking have an increased risk of developing significant pulmonary dysfunction. Air pollution is the leading known risk factor for COPD in persons that never smoked. The inflammatory process of COPD is widespread and involves the airways, pulmonary vasculature, and lung parenchyma. The inflammation is thus present in the central and peripheral airways, presenting with increased numbers of activated neutrophils, macrophages, and lymphocytes. Neutrophils are recruited to the airways of COPD patients and secrete several serine proteases, including neutrophil elastase, contributing to alveolar destruction. Human neutrophil is also a potent stimulant of mucus secretion in the airways. Inhalation of noxious gas and particles activate inflammatory cells and structural cells. Chemical mediators are derived from inflammatory and structural cells in the lung. This includes, but not limited to, lipids, free radicals, cytokines, chemokines, and growth factor. Oxidative stress can also contribute to COPD and is furthermore increased during exacerbations. It occurs when exposure to free radicals, also known as reactive oxygen species, is sufficient to overwhelm antioxidant defenses. Lungs are particularly vulnerable due to the relatively high oxygen environment, increased blood supply, and exposure to environmental pathogens, toxins, and cigarette smoke. Elastin is a major connective tissue component in the lung parenchyma, and the protease-mediated destruction of elastin is an important feature of emphysema. An imbalance between destructive and protective defense systems, proteases versus anti-proteases, in the lungs of COPD patients is evident. COPD is characterized by chronic inflammatory changes leading to destructive tissue changes and development of chronic airflow limitation. An inflammatory exudate is often present that leads to an increase in the number and size of goblet cells and mucus glands. Mucus secretion is increased and ciliary motility is impaired. There is also thickening of smooth muscle and connective tissue in the airways, and this all leads to abnormalities in gas exchange. As the disease progresses, abnormalities in gas exchange leads to hypoxemia and/or hypercapnia. Abnormal low concentrations of oxygen or hypoxemia is initially associated with exertion, but as the disease progresses, it develops at rest as well. Some COPD patients lose the ability to increase the rate or depth of respiration in response to persistent hypoxemia, and this will lead to a further decline in arterial oxygen. Elevated carbon dioxide levels or hypercapnia develop as the disease becomes more severe. Remember, COPD patients have more difficulty to exhale, and the functional residual capacity becomes larger. But how will this affect the acid-base balance? CO2 is an acid, and when retained, it will eventually lead to respiratory acidosis. However, the changes in CO2 and O2 are subtle, and the serum pH remain near normal because the kidneys compensate by retaining bicarbonate. Significant changes in arterial blood gas usually only presents once airflow limitation is very severe. During an acute exacerbation of COPD, changes in arterial blood gases also present. Spirometry is the most widely available and reproducible test of lung function and is used to measure airflow obstruction. Due to decline in lung function, the lungs cannot be emptied during a forced expiration, resulting in a decrease in forced expiratory volume in 1 second and the ratio, which contributes to gas trapping and lung hyperinflation. Hyperinflation is clinically relevant in patients with COPD and contributes to dyspnea, impaired exercise intolerance, development of respiratory failure, and increased mortality. This can be addressed with bronchodilators and oxygen supplementation, but more on this in part 2. Systemic consequences of COPD include weakness and wasting of the body, and a general decline in the overall health status. Systemic effects include cardiovascular events associated with ischemia, osteoporosis, anemia, etc. Dyspnea is a cardinal symptom of COPD and a major cause of the disability and anxiety associated with the disease. Patients furthermore present with chronic cough, which may be productive or non-productive. Keep in mind that the patient may experience cough for many years before dyspnea develops. They might only seek medical attention once the dyspnea becomes significant. The diagnosis of COPD is based on the patient's symptoms, history of exposure to risk factors, and confirmed by a pulmonary function test such as spirometry. Chest x-rays are valuable in excluding alternative diagnosis, including congestive heart failure, bronchiectasis, and tuberculosis. Pharmacists should always work within their scope of practice and refer a patient when needed. Spirometry is a comprehensive assessment of lung volumes and capacities, therefore useful to confirm presence of airflow limitation and to determine severity of obstruction. The FEV1-FVC ratio is a measurement of the amount of air a person can forcefully exhale from the lungs. Should this be below 70% after inhaling a bronchodilator, it confirms COPD. Take note of the timings when a measurement should be taken after the use of either short-acting beta-2 agonist or a muscarinic antagonist. The role of spirometry in COPD is for diagnosis, to assess the severity of airflow obstruction, and the monitoring of the patient. The GOLD guidelines suggest a 4-grade classification of the severity of airflow limitation based on the post-bronchodilator FEV1 readings. Apart from confirming COPD, various tools are available to guide the clinician to treat a patient appropriately. One such tool is the modified MRC scale. This scale categorizes dyspnea from grade 0 to 4. Another tool is the COPD assessment test, in short CAT. It contains 8 statements related to health status and impact on daily activities. A patient is then scored accordingly with a total score out of 40. The MRC scale and the CAT are incorporated into the ABE assessment tool. This tool has been adapted from the previous ABCD assessment tool and now recognizes the clinical relevance of exacerbations. Once a diagnosis of COPD has been confirmed by spirometry, these 5 fundamental aspects must be determined in order to guide appropriate therapy. Take note that blood eosinophil counts can predict the magnitude of the effect of inhaled corticosteroids in preventing future exacerbations and are recommended by GOLD to guide the use thereof as part of the pharmacological management. I hope this recording has given you a good overview regarding COPD. Even if it's not within your scope of practice to diagnose, it is important to know the pathophysiology of a disease so that you can apply the different treatment options. This recording then forms the basis of the next 2 to follow. Until then, thank you and bye-bye.